Okay. Good morning and welcome to Friday Chalk Talk. Today we are going to be discussing practical and ethical considerations in palliative liver and renal disease. We have two lovely guests that I got to meet with last month, and I wish we just taped our hour-long conversation. So I'm really looking forward to getting to hear them talk again. We have Dr. Clara Tao, the clinical site director, hepatology associate program director, gastroenterology and liver diseases fellowship program co-course director. She's got many titles: gastroenterology and hepatology systems course and associate professor of medicine at Montefiore Einstein. She specializes in the treatment of complications of advanced liver diseases, liver cancer, and liver transplant. Her research focuses on social determinants of health and outcomes related to liver transplant and the care of advanced liver disease. We also have Toby, who is certified in internal medicine, nephrology, palliative care, ethics, and POCUS. He's also a moderator for the relationship-centered communication classes at the Albert Einstein College of Medicine. His research interests revolve around palliative nephrology, as well as the application of POCUS technology to palliative care. And a fun fact about Toby is that he used to be the lead guitarist of a band that was once part of Nokia's independent artists in Southeast Asia. This is a sentence I have never said before about anybody, so very cool. So he's got very wide interests. So welcome, Clara and Toby. Today we're going to be kind of reviewing some case studies, so I'm going to let them take it away.
Yeah, thank you so much, Caitlin, for a very nice introduction, and hello, everyone, and thank you for joining us on this beautiful Friday morning indoors. I think that when Toby and I were approached about this Chalk Talk, it's something that Toby and I in the hospital and outside the hospital are always talking about. And so we were trying to think of some cases that could kind of spur conversation amongst the whole group. So we came up with two here, and they were actually inspired based on two very recent cases that we've seen in the hospital. So I'll get started with the first case. So this was a man that actually I had taken care of on the liver transplant service last month. He is a 33-year-old man. He has a long-standing history of active alcohol use disorder, including up until the time he was admitted to an outside local hospital. And when he came in, he had a MELD 3.0 of 40, which portends a significantly poor prognosis. And we were reached out to transfer him for a rapid transplant evaluation, we brought him over immediately. He had acute on chronic liver failure. He had been drinking for many decades and had different hospitalizations related to his alcohol complications. But this was the first time he actually presented in liver failure with his acute on chronic liver failure grade of 3, defined by hyperbilirubinemia, coagulopathy, and renal failure. And his renal failure was extremely progressive and oliguric. By the time he arrived to us, his creatinine was 4 and rising, and he had an intact mental status. And so certainly when we accepted him over to our service, we're a liver transplant team. So the priority was to figure out if he is a liver transplant candidate, but I'm sure many of you can recognize, based on just this very limited clinical data that I provided to you, that we're really fighting against the clock, and that this poor young man may not even survive even the basics of minimal transplant evaluation process. And as you can also see, that he has multiple risk factors for being a high risk candidate for transplant, may not even be listed. And so one of my main priorities when I met him was the questions we have below. How do we address liver transplant candidacy and the evaluation process at the same time that we know that someone is at such imminent risk of dying before we may even be able to answer this question and try to save his life? And should we consider kind of very heroic life extending measures, temporary extending measures such as dialysis in this patient while we are trying to figure it out? So I don't know, Toby, if you want to start off with some comments first about this case.
That's something that I think we all see in the hospital quite frequently, and wearing my renal hat, kidney hat, or PP hat right now. Um, it's always something that I like to discuss with the colleagues. I think the first thing that I would like to comment on is, the mental status, functional status is really something that's important to us, right? One of my former mentors joked that we try not to dialyze anyone with a low neuron to nephron ratio. So the just seeing the patient, having this conversation at bedside with the family is really important. Plus, again, as you mentioned, Clara already, I think the relationship between the nephrologist and the hepatologist, which historically hasn't always been great, is very vital to be conducive to, to get the best care and outcomes for this patient. That's kind of like the general mindset I have approaching these cases.
Yeah, I agree. And Toby, I love that you mentioned the relationship between the hepatologist and the nephrologist. Um, for those of you who know me, which is really just Toby on the call, and Caitlin got a little flavor of me last month. I try to be pretty straight up, but yes, there does tend to be a little bit of disagreement that can happen between hepatologists and nephrologists. Um, and I think some of that stems off of how difficult hepatorenal syndrome is to define and to diagnose. And if you actually look in the clinical literature for anything related to HRS, which portends such a horrible prognosis without transplantation, the gold standard tends to be a committee of hepatologists and nephrologists retrospectively looking at cases to come up with a consensus of what the ultimate diagnosis was, which always makes me kind of question the HRS literature on it. But HRS is an extraordinarily difficult diagnosis to make. And I think that Toby and I can agree that knowing the difference between, let's say, HRS versus ATN can actually have significant prognostic implications for a patient, even one as sick as this. And our diagnostic tests can often fail us, and it leads to a lot of interpretation of history, what has been happening. A lot of those details are lost at another hospital, and then we are left with the question of, can dialysis help temporize these patients until the hepatologists can figure out what to do with them in the big picture? Yet starting dialysis is a very big part of that big picture.
Yes. I think you touched on, I'm sorry if someone has any questions, obviously specific to the case, please feel free to chime in. But I think you touched on so many good points there. The number one thing is it's so important. I can't emphasize enough the communication piece here. I want to acknowledge everyone being uncomfortable taking care of these patients because there's so many unknowns, right? Usually in our hospital too, once we get called in, the patient is already on what they call the hepatorenal cocktail, right? Like the HRS cocktail. And in that case, again, it's hard to differentiate diagnostically whether this is HRS or ATN. And therefore, you're in trouble. I have too many kidney jokes. But there's a lot of confusion, us being uneasy about this. So communication, not only with the patients and their families, but with each other, right? That's such an understated skill to have right now as providers. And then I think I have a question because even before we go to dialysis, I guess one question that I know we've talked about in the past was we always get this confusion about should we even talk about dialysis among doctors, much less offer it to providers, because would AKI be either one, something that would preclude a cirrhotic patient from being a transplant candidate, or number two, would actually starting dialysis be more conducive to them? Those kind of related questions to being listed.
Yeah, and I think Toby, that's a great question, and think part of that question is inspired by another case that is ongoing right now in the hospital, which we don't need to talk about today. But I will say that providers who exist within the transplant world have a very different approach to medicine surgery interventions compared to those who are not in the transplant world. And what I mean to say is that we are extraordinarily goal oriented to say, and it's a little black and white in our thinking, transplant, save a life, no transplant, this patient's going to die. But when they're going to die without the transplant is highly variable based on the patient case. And so when we think about the goal to transplant, I would say, to oversimplify, there are two main goals that we have. One is, can we medically stabilize the patient long enough to even make a decision about transplant candidacy, such as this gentleman? And the second is, if they are about to be listed, or we are optimistic that they'll be listed, or they're listed for transplant awaiting organ offers, we as medicine doctors actually have to do everything we can to have them stable for surgery. So what I call surgical optimization. And in these patients with very bad portal hypertension, certainly electrolyte management is essential. A lot of times we can manage that medically without dialysis, but fluid management is significant for the surgeon. So patients who are very fluid overloaded, have profound anasarca, have significantly worse outcomes after these major surgeries compared to those who are euvolemic. So it's not necessarily that the renal failure itself is the barrier to transplant. It's more about the sequelae of renal failure that portends poor prognosis after a surgery or getting to surgery.
Got it. That's a very important distinction to make, because the traditional, I'm going to say, indications for dialysis have a lot of gray zone there. This is where possibly patients like the one in the case would fall into. So to answer the question, would we consider dialysis in this patient? Absolutely, right? Now, I say that with conviction, but I think what's important, again, is you talk it out with your colleagues, with a hepatologist. You have a conversation with the family too. And what I would say is that for patients like this 33-year-old gentleman, we have to set goals as well. We used to call them time-limited trials, which I'm not such a big fan of, because it kind of denotes some urgency and some deadline for the patients and their families, right? I like telling my patient we need to have goal-oriented trials too. Meaning, all right, for this particular case, what we're trying to do is we're trying to correct his or her volume status enough so that they would be a better candidate for surgery and transplantation. But then I would discuss with them that, obviously their hemodynamics may be a little bit labile, and the amount of fluid that we're able to take off, as much as I want to remove everything in one go, will be limited by their capability to tolerate massive fluid shifts. So I have these conversations with them and say that, okay, this is the goal, but if we don't reach that goal, we're not going to keep our patients on dialysis forever, long term.
Right.
And these are the bumps we kind of anticipate along the way, and this is what we're going to do. But in the end, if we can't reach that goal together, and we're going to work on this together, then I think that's the time we start having reframing our goals based on those changes, those developments. So I think that's a very important distinction to make, because a good goals of care discussion is always anchored on a good prognosis. That's what I always say. For these patients, as you mentioned, we know it's a poor prognosis. We have maybe a wonky sense of time. So it's really hard to tell the patients, like, minutes to hours, hours to days, days to weeks, weeks to months exactly, especially if transplantation is still being offered on the table. So the best thing, if we don't have a good sense of life expectancy, is that we set goals. Instead of saying it's just time limited, we're just going to do it for 1 week and then done. We're going to pull out the shyly, so on and so forth. So I know there's a lot of meat left on that bone that I left. So I just want to make sure I open it up to everyone too, what their thoughts are, if they want to share their experiences on dialysis and these patients.
I just want to note that here at St. Luke's, we actually have a colleague whose whole area is liver transplant and working with this, and she's unfortunately on vacation today. So our primary person who would work in these areas is not here. So you might hear a little bit more silence, and that is okay. But I think kind of inherent in how you addressed the second question on your slide was also an answer to the first, addressing that idea of transplant candidacy and end-of-life decisions at the same time, because there is so much uncertainty inherent in all these conversations about goals is what is that end of life is possibly near. And so are we trying to really push that out? Are we trying to buy time? And just sitting with that uncertainty sounds really difficult. Marty also says he has a question. I will graciously allow.
So I hear you guys saying that it's really important for us as a palliative care team, adding another cook to the kitchen, is to appreciate our colleagues' distress in this and really empathize with you guys. Over communicate. I mean, over communicate, not just send some text message or a secure chat. How else do you think our team can be helpful, and what are maybe some of the pitfalls that you've seen palliative care teams stumble in when we try to enter into this really complicated kitchen?
You know, I think it's a lot of the pitfalls that I've seen are due to, as Toby mentioned, a lack of communication. And a lot of that is either driven by big hospital systems where people just don't know each other. I mean, I have Toby's cell number, so I can call him anytime. I have a lot of our Pal Care attendings numbers. But I've been here a while and everybody kind of knows me. It's easy to talk. So there's a lot of barriers in terms of the size of the system. You're having new attendings come in all the time. And also just the failure of the electronic medical record system, right? I don't know how you guys operate, but for us, you put in a consult through the EMR. You have a few limited characters or a button to click, you know, like, why are you calling the consult? And then your fellow or the attending who's on service sees that they want to get the job done as quickly as possible. And there is no time or space to even think about how many layers there are to this consult, for example. And that's where actually I find we run into the most trouble. So a lot of times I have learned throughout the years and through my relationships with other consultants that don't even put in that order first. I'm just going to call, let the person know what my goals are for the consult in a conversation and really give them the background. I also like to get into the psychosocial so that you guys aren't just walking into the room blindly without knowing what I've told the patient and the family. And then after that, I say, okay, I'm going to put in the order now, but don't let your fellow go crazy thinking this is just like an end of life conversation. I think in the world that we practice, it's really hard to take that step and stop and do that extra communication. And that's when things tend to fall apart. And it's really not fair to you guys because I feel like your field is so much more complicated in what you walk into. And yet you get 5 words of a consult request. And your consults take so long that you're just trying to get through it over the day. So things that I've seen most of the time is that a palliative care team will call the family to get some collateral information or walk into the room, and they're getting bombarded by the family about what's going on, you know, what's the deal with transplant. And then they think that, oh, well, they called me. Sounds like they're not a transplant candidate. But actually now we call much earlier, even while we're actively doing transplant evaluation, because we don't know which way this is going to go. I mean, this is a very extreme case, a MELD 40, right? This guy has hours to days to live, I would say. But really all of our acute and chronic liver failures and cirrhotic patients that are in the ICUs, even if we think they could get better, right? in the short term. In the long term, it's very questionable, and we like to get palliative care involved earlier and earlier, which I'm sure is better for multidisciplinary care. And so we've had a lot of cases that came up in the last several months, especially when we had an influx of new attendings, and some attendings who are not worked at transplant centers before, where they come into the room and they're talking about end of life care, saying that this is the destination, as opposed to this is one part of a very complicated conversation about your overall care, and that we need to be prepared for every path because we don't know which branch we're taking at this point.
100%. I have minimal things to add. I think you kind of just hit the nail on the head there. From a palliative side, though, there's a few things we've seen, and if I could simplify things too, you've touched on all these things. Number one, it's the prognostic uncertainty, right? How can we have a good goals of care discussion if, again, will the patient get dialysis? Will the patient get a transplant? Will the patient tolerate dialysis or not? Second thing is communication. A lot of players on the team. Sometimes, and everyone has a voice. Sometimes it gets a little bit muddy there. The third is part of that too. It's like we almost play a game of chicken, right? Whenever there's a hepatologist and nephrologist there, and both organs are failing, who's first to admit defeat, quote unquote, right? Who's going to broach goals of care discussions first? And we always kind of like defer. Now, this is a liver problem underlying. And no, the kidneys are, they're more pressing right now. The patient's electrolyte abnormalities. So sometimes we kind of just get into this phase that, we'll just defer to our colleagues to be the one to initiate. And then the fourth one would be hospice eligibility too, right? With multiple life-limiting diagnoses, that gets a little bit challenging too, especially if patients are dialysis dependent at that point. We're not yet in the world where palliative dialysis is something that's widespread, accepted, or established. But yeah, those are the things that we've identified that are challenges also for palliative care in these patients.
Yeah, and just to piggyback off of that, I think that as we are all human beings with many, many faults, as we get these bad experiences where calling consults didn't really go the way that we had expected and it leads to conflict, a lot of transplant people who shall not be named, otherwise, I might get in trouble, have fallen away and are now completely fearful of palliative care. You guys are a very intimidating bunch. But I mean, I've certainly had some colleagues, certainly of a more surgical flavor, particularly, who are just saying, you are not allowed to call a palliative care consult because we cannot have this. We cannot risk having this happen again, which is totally not the right approach at all. But we are emotional beings that remember the last one or two cases that didn't go the way we want, and this is how we react. And it takes a very long time to wash out that experience, which is very unfortunate. But going back to this patient, what really surprised me in this case is that while this young man was in such bad liver failure, as I mentioned, his mental status was intact, and actually, despite poor health literacy background, was actually able to have quite sophisticated conversations with me about my fears that I wouldn't be able to save his life in time to figure out transplant candidacy, that he could die on me tonight while I'm actively trying to figure that out. And that if we were spiraling out of control down this path, how can he feel about suddenly shifting from this full aggressive try to save my life to I want to be comfortable. And he essentially told me, and his family deferred to him, that he understood that at the moment that I had met him, that his candidacy was very unlikely. And that if it remained unlikely, he would not want dialysis, or we do plasmapheresis in these acute and chronic liver failure patients. He would not want ICU pressors, a line in his neck, all of these things. But if there was a point, and he deferred to me, where I felt that there was optimism in his candidacy, he would change his mind. So he trusted me a lot with that. And I was very appreciative in that, because within 36 hours, he became very altered and was not able to discuss with me further. But I felt that I had understood him well enough to know that at that 36-hour point, I had learned actually enough about him that I thought there was more than a 50% chance that I could list him for transplant from a psychosocial risk standpoint, which was his main barrier. And so with the family's permission, we actually did put him in the ICU. We started him on CRT and plasmapheresis, completed the rest of the little medical testing we had to do. We listed him, and he actually did successfully get transplanted, and he is doing well.
Thank you for that discussion. That was fascinating.
Yeah, I mean, and I was skeptical the whole time whether we would even get to that point. He was definitely a surprise case for me, because there was a lot in his history that was really fighting against him, but there were just these crumbs that I was discovering along the way. And the team was just, kind of getting on board and understanding him better. And yeah, I mean, now if you talk to him, I don't even know if he remembers our conversation.
Yeah.
It doesn't matter. But I will say that this is a rare exception. I would say the vast majority of patients who come in like this are not getting a liver transplant.
Yeah.
Either because they're just too sick and they can't make it, or there's something in their alcohol history that is too severe, that we cannot overcome those psychosocial barriers and unfortunately the addiction disorder.
I want to make sure we have time for our second case, but because I'm moderating and I have also written down almost the same question that Lisa has in the chat, I'm going to ask that before we move on, because I'm in charge. Not really, but I really like her question. How would a diagnosis of ATN versus HRS change your approach, if at all, in a case like
gosh.
this? Or just
I love that question. How much time do you have?
That's like a 3-hour
3
talk
minutes.
Well, in the interest of time, we used to think that, and Clara, I apologize, I'm stepping on your toes here.
No, please go ahead.
I just love this question too, because it's something we ask ourselves all the time. And here's the gist of it, if I can simplify it in a few minutes. We used to think that hepatorenal syndrome was this dichotomy, right? Whether it's HRS yes or HRS no. We're finding out that HRS physiology is actually more of like a spectrum, kind of like prerenal and ATN. So there's a lot of hepatorenal physiology going on in these patients, even with ATN. So that's the first point I want to make. That it's not just either ATN or HRS, it can actually be HRS to ATN. But the second point here, if I can simplify it again, is it's a volume thing, right? Labile hemodynamics, I'm going to say. Because if the patient's ATN, then you think about most common causes statistically, right? Which is in these patients or anyone in the hospital, it's pre-renal, right? So you address those things, whether it's pre-renal, we're not perfusing because the patient's not eating, because they're shocky, because of abdominal hypertension and the renal veins are collapsed, right? That's why none of the diuretics are working, so on and so forth. Well, in HRS, as we all know already, and we're not going to maybe, in the interest of time, go through that. It's a different pathway you get into in terms of acute treatment. The third thing I'm going to say is that in terms of prognosis, both would just be awful, right? Up to 50%, and anyone in the hospital with an AKI needing dialysis, especially in the critical care units, you would actually approach 60%. So both are just like awful things in terms of prognosis too. Yeah, I mean, gosh, I know I'm not doing the topic justice, but those are like the three things, if I can just summarize really quickly, ATN versus HRS and how we differ in our approach there.
Yeah, and I think just from like a mere hepatologist, non-nephrologist perspective, right? HRS, you're dead without a liver transplant. ATN, let's say if this patient, their MELD was only driven by renal failure and not so much coagulopathy and hyperbilirubinemia. If that renal failure were HRS, the need for transplant is urgent and dire. Whereas if it's from ATN, there's a possibility of recovery, and there is possibly less likelihood of worsening liver failure in that context. So it's a little bit different.
Yeah.
In addition to all the ways that you have to manage it and how quickly the patients deteriorate in front of you.
Exactly. I know I'm not touching on like which fluids would I like to choose, right? Because we like using albumin for endothelial dysfunction and HRS. Would you do large volume paras, all that stuff, which is a different mindset, really. But yes, I apologize. This is a palliative care discussion. So
That's okay. But speaking of paracenteses, which ascites, I will move us on to our second case. And I'm loving this discussion. Thank you all.
Yes. So this second case, I'm sure you see way more often than the first case. So it's an elderly woman with cirrhosis. She has large volume ascites, that's diuretic intolerant. She has HRS-CKD, and she comes into the hospital with recurrent worsening volume overload and acute on chronic kidney dysfunction. She's been getting large volume taps every 2 weeks for the last 6 months. And she, let's just to say for simple reasons, is not a transplant candidate. And so the questions are, what are our options for treating her ascites, and would we consider dialysis for volume management?
okay.
I don't know if anyone in the room has any thoughts about this case. I'm sure it evokes a lot of emotions in all of us.
It does. I'm getting traumatized again. So
I can feel Toby already.
I know, well, let me punt it over to maybe Marty or Caitlin or anyone else, and I'll be glad to chime in. Maybe I can ask because every place is different here. Yeah, I mean, what's the usual approach in your institution? Because I tell you, like we've seen patients with cirrhosis, and if I can say, like their symptom burden is just horrible, right? Horrible. They get jaundice, so the sense of dignity also is lessened. They get pruritus, which is so hard to treat, so difficult to treat. They get swelling as well, so they get debilitated. And then the ascites, which, it's been a while since medical school, but I think there's so many organs in our abdomen and our chest cavity that get affected. The breathing gets affected, early satiety, nausea, and vomiting. So when someone comes in with diuretic intolerant ascites, recurrent ascites, it's something that I think is even haunts palliative care providers on a daily basis. It gives them nightmares in terms of symptom management. So maybe I'll just punt it over to the palliative care team there about maybe what are your thoughts here? Like what's the usual thing that you guys do when patients like this walk into the ED doors?
We sigh deeply. Oh, you again. No. I think I'm not sure I know enough to be like, oh, this is our definite standard approach. I think the typical palliative care approach would be the question of what are the goals of care for this patient, first of all. I think it's very easy to see these patients on kind of a treadmill that, okay, I come in every few weeks and I get tapped, and maybe I get a little bit of an infection. I stay for a little while, but continuing. And so do we stay on the treadmill? Are we comfortable here? Is there a way to get off? So I think that would be my questioning approach for this patient. What is her quality of life like? What is she hoping for? What is she worried about? Where are we going? And then of course, communicating with, hepatology and nephrology. What have your conversations been as well? I don't know, Marty, what you have to add.
I see remarkable resemblance between this case and the last case, because as people get older, the benefit of dialysis shifts and it changes. As people have more comorbidities, that benefit potentially shifts. And I worry about this patient because we're dealing with some muddy uncertainty here. Maybe a patient like this might benefit in some way from dialysis. I worry that the more likely situation is it may not, but I really feel torn that I'm not going to be able to really lead this patient clearly, that we're going to have to walk through the mud together.
I think that's a very excellent point that you brought up, Marty. And I see Cindy just mentioned about a peritoneal catheter. Yes, we are going to get to that. I find that there is some mental block with physicians from many different divisions or departments and ascites, particularly in the inpatient setting where patients come and go without the continuity of a particular provider. Because if you actually talk to the medicine house staff, they think, oh, an ascites admission is actually a very straightforward, easy admission for them. They come in, they get to do their POCUS, they get to mark off a procedure on their checklist. The patient feels amazing after an LVP. The patient's so grateful and happy, and then they go, and it's all done. But what we all forget, including hepatologists, I will admit, is that patients who cannot tolerate or are refractory to diuretics, forgetting their MELD score, has a 50% mortality at 6 to 12 months. So the prognosis is actually extraordinarily poor in these patients. And so we fall into the cycle of forgetting their prognosis, feeling that there is something quick to do that easily makes someone feel better. But actually over that 6 to 12 months, the patient is actually deteriorating in front of your eyes, predominantly from a sarcopenia frailty standpoint. They get worsening encephalopathy, risk of infection. And actually you're doing a patient a disservice by keeping them with these TAPs and not really discussing what their goals of care are. And, you know, hepatologists fall into trouble with this in a particular way because we so don't want this to be true. We keep trying the diuretics. Oh, maybe they failed diuretics that time because they had a UTI. And then they failed diuretics this time because they were having a GI bleed. And then they failed diuretics this time because maybe we overdid it. And the lie perpetuates in our mind. We fool ourselves. And then 6 months go by and the patient is still getting TAPs. And everyone else feels stuck because even the hepatologists themselves feel stuck. So this is like a very common problem that comes up. Yes, thank you, Marty, the hope. Hope is very good in many ways, and hope is a very good set of blinders in many, many other ways. And so I've learned over the years, and I had a mentor in my training who kind of put it very simply. He's like, if you keep failing and doing the same thing, you're actually crazy. So I've learned to kind of give myself hope once or twice, and then after that I come to the reality of the situation. So I'm much more aggressive about saying that someone is not diuretic tolerant, that someone's prognosis is very poor much earlier on than I used to when I first started my training in this field. And so my shift in practice has been that if I cannot find you a way to get to transplant, then we really do need to talk about prognosis, symptom management. And that's very difficult because these patients see it the same way we do. I get a TAP and I feel better. I get another TAP and I feel better. It's very hard to fight that. And so even now, I don't even know if I'm allowed to say this out loud, but I've become more paternalistic in my approach. And even if a patient is not fully accepting of hospice, goals of care, all of that, their prognosis, I will now push for a peritoneal drainage catheter sooner and just explain to them that essentially we are palliating you. We're just not using the technical term palliative care or hospice because you don't like those words.
Yeah.
Um,
So I said it before, and I'm gonna say it again. I knew it. No, just joking. So this is this is the nephrologist.
Look, not everyone feels the same way I do, I will admit.
No,
But
no,
usually
no.
when I see my colleagues' cases like this and I call them, because I do a lot of inpatient consults, I'll just say, look, X, it's time and I'm doing it. And I'll say it in the affirmative as opposed to asking permission, because I've learned to not ask for permission for things anymore. And if you are silent, then I have your sticker of approval and I'm doing it, unless you have a really good reason to convince me not to do it.
Yeah. But yes, no, I think going back to the whole diuretics and just like perpetuating it, you've seen, you've seen it. I've certainly been guilty of it. That we've given patients super doses of diuretics, sequential nephron blockade. That patients are now deaf and can't have goals of care discussions because of all the toxicity. But
Oh
then we
yeah.
just, the nephrologist, even like myself, again, I'm guilty of it. We don't kind of also want to admit that, all right, maybe it's time to talk about, dialysis. To answer the second question, again, goal-oriented dialysis, not just dialysis. I'm gonna put you on this train. It's gonna run forever until it runs out of, of fuel. Now, yes, my approach here is, after maybe 24 or 48 hours of fighting with hepatology, then once we get to really talk
Toby and I
about
don't fight, just so
no, we don't.
Don't believe you.
um, then we talk about, again, look, we've pretty much exhausted, super maximal therapy here. Um, if the patient is a possible candidate for transplantation, then we do have that dialysis conversation. I still offer dialysis for patients. I don't want it to feel that dialysis is kind of just always a bridge for transplantation. Maybe that's one thing I want to clarify too, because I've certainly dialyzed patients who've had, really grim prognoses. And again, but the goal should be there. Like when I was practicing way back when, I had a patient who, for a different indication, was going to failing kidneys, and he said, you know what, I just wanted to catch this season one more time because his cows were going to give birth or something like that. He really enjoys that time of year. And I'm like, you know what, buddy? Yeah, we can do that. So we ended up putting him on dialysis. We didn't put in a fistula. We put in a permacath. And, he followed up with me after that. I said, you know what, doc, I'm good. I'm done. And then, so it's just a story to say that everyone's goals are different. I just don't want to feel like, as nephrologists, we're relegated to just doing dialysis or considering dialysis only for the bridge of transplantation. We certainly do it, for example, to buy time for high risk of complicated grief with the family dynamic, right? So that they can talk it out, that we can have goals of care discussions with the family, to have bereavement counseling instituted, so that just to buy time. We've certainly used it for that purpose too. So yes, would we consider dialysis for volume management? Um, Definitely. Again, it's really important to talk it out with your colleagues. Everyone's on the same page. And then I think, sorry, Claire, I interrupted you. We're about to talk more about the other options for treating the ascites, which Cindy also alluded to.
Yeah. And I think just to add one quick thing, like,
Yes.
right, patients who are predominantly ascites as they're manifesting overload, right, have more options, as in a peritoneal drainage catheter, versus the patients who manifest as, I call Michelin Man, the anasarcas. And we do see more palliative dialysis in the anasarchic patients. They want to make it to their daughter's wedding or something like that, you know? So I think the anasarca patients actually tend to be more challenging than the predominant belly patients.
Yeah, they're correct. I think you've seen that too, that going back to a little bit of my, renal hat here, the white whale, the golden goose, the fountain of youth that everyone's been trying to seek an answer for is capillary refill time, right? We've seen patients who we diurese and they're fine. They pee out like 20 liters a day and they remain hemodynamically stable. And we've had another phenotype of patients with diuresis, and their blood pressure tanks, and they're intolerant of higher doses of diuretics. And the issue there, again, in a nutshell, is that people just have different rates of filling up their intravascular space again, right? So yes, the anasarca part is just so difficult to manage. And as much as I want to guarantee, for example, we've gotten asked to dialyze ascites off. It's it's a different dynamic there because again, we tell them that the dialysis catheter or the fistula goes to your intravascular space. A little bit difficult to force the fluid from the belly back into the blood vessels, the capillary refill time. But it is something that we get asked to do. But just to acknowledge what you said, ascites, we have a lot of options there. Dialysis may be lower on that list. Anasarca, yes, dialysis may be higher, but it's really difficult because of those different phenotypes. And most of the phenotypes you see in the hospital, because of a selection bias, are those patients who remain hemodynamically unstable, unfortunately. So, yes.
And so options for treating her ascites, you could continue serial large volume paracenteses. It's painful, there's infection and bleeding risk. Patients have to come into a procedure area every few weeks. Some patients are willing to do it, but to me, oh gosh, it just seems so unpleasant. I would not. I'd probably tattoo on my belly, like no feeding tube and no taps. There is the option of a peritoneal drainage catheter. And for patients who are on that, I actually do put them on SBP prophylaxis just to reduce risk of infection. And sometimes you get burned, sometimes they get infected and they have to be admitted, but it's not that common. You could consider a TIPS, which is a shunt within the liver, to see if that can help manage, but that's pretty invasive, risk of encephalopathy, risk of liver failure. And so oftentimes for a patient like this, we would not recommend it because we'd rather not cause harm with an intervention that may not even work. And then there are some very old school kind of surgical or IR shunts where essentially the shunt diverts the ascites back into your vasculature. They are so rarely done. They generally call it a Denver shunt. They don't work that well. And if you get an infection in your belly, then it's going straight into your blood supply. So hepatologists notoriously don't like it, and that's probably why it really doesn't get done. But it is an option for patients who really want something that does not lead to a tube outside their body.
Yeah.
So.
Thank you. This is really, really interesting. I'm so grateful for the time and the extra time you've given us. Any final words, points you wanted to make but just didn't come up, pearls that you wish palliative care teams knew or kept in mind when working with your population?
Hard for me to separate myself from the palliative care team, but I'm just going to say, especially for nephrologists, please be patient with us. And also, I'm so sorry.
And I will acknowledge that hepatologists are very strong-minded.
It's probably a good thing.
Yeah, but we're very mushy inside.
As all humans are.
Yeah, exactly. But thank you so much, everyone, for inviting us today. This was a lot of fun. Toby, it's always great to talk with you, as you know.
Thank you.
This is so interesting.
If anyone has any questions, just feel free to email us.
All right. Thank you, guys. Bye. Have a good day.
Happy weekend.
Happy weekend.